Hello, everyone, and welcome to The Rookie and the Vet, a series all about what the Healing Cycle Foundation does, how we support Ontario hospice and palliative care facilities, and how important hospice facilities are for the residents of Ontario. My name is Mallory McGrath, a.k.a. The Rookie, and I am from the millennial generation. Those are people born between the years 1981 and 1996.
And hello, everyone. I'm Ron Kassies. I'm the chair of the foundation. I'm the vet. The color of my hair probably clues you in on that. But anyways, I'm from the boomer generation. Those are people born between 1946 and 1964.
So today we have a great guest here on episode 7 of The Rookie and the Vet. We're going to learn all about what it's like to be a palliative care clinician. So let me introduce you all to Dr. Bob Sauls. I'm going to actually read this just so I get it right. So he worked with patients up to 2018 and also worked for the Ontario Palliative Care Network in 2017 through 2020. While he was working there, he was the lead for the development of a framework for the delivery of palliative care services in Ontario. He was also the provincial co-lead in 2019 and 2020. He's now retired, but he still provides the occasional input around provincial planning for palliative care services. Dr. Sauls is also an avid cyclist who's been participating in the Healing Cycle ride since our beginnings 16 years ago. So thank you so much, Dr. Sauls, for joining us today.
Well, thank you for inviting me. And I guess I should declare that I'm fully within the boomer generation.
Thank you for sharing that. That's great.
It's nice to have company.
Yes, I know. I always, Ron and I definitely have our differences, but it's always interesting to see the similarities between the generations as well.
And you can call me Bob.
You can call you Bob? Great.
Yeah.
That's wonderful. So Bob, could you maybe fill us in a little bit about your history in this industry, as well as the work that you did as a palliative care physician?
Sure. I really started early in my career in working in palliative care. I came out to Mississauga, which is where I worked back in 1985 as a family physician and emergency physician, worked in the hospital. And early in my family practice, I had patients in my practice who developed serious illnesses, who came to the end of their life due to whatever illness they might have. And it was actually pretty compelling to me. I could see their needs. I could see that this was something that was important for me as a family physician to be doing. Mm-hmm. I also had I was fortunate in my training. One of my supervisors was one of the pioneers in Canada and Ontario in palliative care, a fellow by the name of Larry Lebrack. So I had some ideas about this, what this was about. Didn't quite have the skills yet. There was no training back in those days. And so I just gradually was doing it more and more. I was working in the hospital, and of course in the hospital, people see what you're doing. And I started to get referrals from the oncology program, because for people who either didn't have a family physician or whose family physician wasn't comfortable with palliative care. Mm-hmm. And then I was doing home visits out in the community, and the nurses in the community would sort of see that as well. And I got more referrals from them. And so my practice around palliative care just grew over the years. And then we opened a palliative care unit at Credit Valley Hospital, now part of Trillium Health Partners. And we expanded it in 2012 based on funding from the Healing Cycle. And then the latter part of my career has really been focused in on how do we ensure that we're delivering high quality palliative care everywhere in the province, wherever people need it, whether they're at home, in the hospital, on an Indigenous reservation, homeless, that we need to make sure that everybody has access to this. And so it's been a pretty rich career.
That's wonderful.
Yeah, it sounds like it, Bob. Your professional experience, how you brought yourself into this field is it's remarkable. For back, like you were saying earlier, there's no training involved in that. But one of the questions I had as well is, can you tell us the difference between palliative care and hospice care? Because I kind of put the two together, but there probably is a difference that people should know about.
Well, They are, in Canada in particular, we do link them to a certain extent. In fact, in Canada, we refer to hospice palliative care. It's the language we tend to use in Canada.
Mhm.
Part of the explanation really goes back to the beginnings, which, the whole concept of hospice started in London, England in the late 1960s. Dame Cicely Saunders, a physician, led the opening of St. Christopher's Hospice in London. And that was really focused on end-of-life care, people in their last days, weeks, small number of months. And then in the 70s, a physician, actually a surgeon, interestingly, from Montreal, Balfour Mount, went to London and learned and worked or spent some time at St. Christopher's and brought the ideas back. The word hospice apparently didn't work so well in the French language, and he coined the term soins palliatifs, palliative care. And the ideas of hospice and palliative care came to Canada and the United States. And in those early years, it really was focused on end-of-life care. Palliative care programs tended to be somewhat physician, nurse-led, whereas hospice programs were broader based. They were led by social workers, community organizations. And I mean, we move to today, the hospice residences are still very much, for the most part, focused on end-of-life care. But when you start to talk about palliative care and hospice care, we've moved way upstream early in people's illnesses, seeing people who are still receiving care for their underlying illness, whether it's chemotherapy for cancer or dialysis for kidney failure or aggressive treatment for heart failure. And when I think about hospice services or hospice care, I listened to your interview with Jodie Pereira rather, from Heart House Hospice. And when she described the services provided out in the community, that's when I think about hospice. I think about, what services does this hospice program bring to support the person I'm caring for, regardless of where they are in the course of their illness. So we're really moving way upstream from end-of-life care, both within hospice. I think one of the challenges is both palliative care and hospice, those words still tend to conjure up, images of end-of-life care. And I think we still just have some work to do to change that perception.
Yeah. That's actually a great point to end on. That goes into our next question, because I really do personally find this topic really fascinating. And I'm relatively new to the board, in that I've been on for about 6 months now. And so I knew somewhat about hospice palliative care, but had really only ever been to one hospice ever. And it was in the States when a great aunt was dying. I had very limited understanding of what it was about. And so in the work that I do with end-of-life planning, I see a lot of resistance around talking about any sort of end-of-life or aging care, right? And so we're definitely a death avoidant society. And I'm wondering if you can think of ways that we can change the way that people view talking about palliative care, hospice care, end-of-life care, something like that.
Well, I think there's a few ways. One of the things in my observations over the years is that people who are more comfortable talking about these issues are people who've been exposed to it. Either they had a family member, they've had a family member, as long as their experience wasn't awful.
Right.
And even you think about the healing cycle events, you go out there and there's this community of people, most of whom had some kind of experience, and they're willing to talk about it. There was an ethicist from New York back when I was first starting in palliative care, who wrote a book called The Nature of Suffering. And one of the things he talked about is how we isolate the sick and the suffering. We avoid them. We talk about them in whispers. And one of the movements occurring, it started in the UK, it's now occurring here, is what's called compassionate communities. And how do we, as not as healthcare providers, but as communities, engage the people in our community who are sick and suffering and maybe coming to the end of their lives? And I think just on a practical basis, within 200 meters of my house, there are 3 couples who are over the age of 85.
Mm-hmm.
They're well right now, but one of my thoughts is, what's my role as their neighbor, not as a physician, but as their neighbor,
Mm-hmm.
engage people. So part of that is developing this idea of compassionate communities, that we stop avoiding the suffering and the sick. The other way, I think, is much as what you're doing. It's how do we engage the public in these conversations? I think back to a few episodes where I did some talks at church groups, some of the richest conversations I had in my career. And I think, and there's lots of organizations that do this. I think that needs to become part of our actual provincial strategy, is how do we engage the public in these conversations, talking about these issues, talking about what palliative care is.
Mm-hmm. I completely agree. Mm-hmm.
Yeah. So to pick up on the question Mallory just asked, we're just curious, what are the most enduring myths or misconceptions to overcome when it comes to palliative care?
Well, I think, if I would focus in on one, it's not only in the public, I think it's sometimes in healthcare world as well, is that palliative care and hospice care is all about dying. That, one of the things, and that really when I think about it, palliative care is maybe more about living. And because really what our focus is on is how do we help people live as well as they possibly can during this period of time in their life.
Yeah.
When I would see people for the first time in the clinic setting, I usually would ask them, okay, you've been referred to this clinic, the palliative care clinic. What do you think that's about? And would kind of get that out of the way right away. And then would focus in on, well, what is it that's interfering with this person's quality of life right now? Is it pain? Is it emotional distress? Is it family challenges? Is it practical problems?
Yeah.
Because really our goal is around how do we facilitate these people to live well? What we know from research is that people who receive palliative care alongside other treatments, whether it be, again, treatments for their underlying disease, they do better than people who don't receive palliative care. There's been studies that have shown people have better quality of life, less depression, less anxiety. There was one study that showed that there's one group of people who actually lived longer. And those of us, though, who work in this field just would anecdotally tell you that we've seen remarkable things, that if you support people and, again, get rid of those things that are interfering, there's just remarkable things happen within families, and what families can be if you create the space for that to happen. I think back, my mother died some years ago in the care of a hospice program. She died at home. And, after she died, I remember my father talking about those months at home and saying, it was really hard, but that it was probably among the richest times of their 50-year marriage because they had that support to be able to live those years.
That's really beautiful. I actually had a recent interaction with someone who was talking to me about working with an end-of-life doula and the support that she had as her husband was dying, and that her husband, verbalized his fears earlier on in his end-of-life process and died in this very peaceful and accepting way because he was given that support that sometimes needs to be a person outside of a family unit to come in and almost give permission for those conversations to happen. Because I think that as a society, we still view talking about these topics as being depressing, and that person talks about death a lot, and they see it a lot, and that must be so sad. But it can be also a beautiful part of a journey to witness.
Well, and I think the other piece of it is that there is a time that to talk about death and dying. And but sometimes I think even among palliative care, sometimes we rush into that before people are ready and before it's the right time. And I think we need to walk with people where they're at whatever point, which also argues for earlier, getting to see people earlier. If you're getting people at the very end of life, you're kind of rushing to catch up. And so one of our big and, sort of goals is early identification of people who have palliative care needs.
That's great. And so just one final question for you today, Bob. So it's more of a personal question. Is there a moment or a story from your decades of practicing in this much needed field of medicine that you could share with us today?
Well, there's a lot of stories, 30 some odd years. I think what I would maybe describe as more of a collective story. Over the years, I've cared for people in the hospital, in my family practice office, in a clinic. But really, maybe the setting which has been most striking for me is caring for people in their homes. And I've done many home visits over my career, and it's you see people in a clinic and a hospital. These people are on your turf. It's your rules. You go, and it's awkward for people. You go into their homes and it's turned around. It's their rules and their home. And sometimes it could be, when you first start doing it, it's a little intimidating. But it's just an incredibly rich experience. You go into people's homes, they're more at ease. They're in their own setting. Families are more at ease. Families, gather around. I've had go in there and there's 10 family members all there listening and talking and asking questions. They're comfortable asking questions. And you just learn so much about people, and people are so warm and inviting when you're coming into their home. And I remember sometimes I have to, go in there and, I've done the medical things and now there's a meal. And I remember one story from there that's just sticks with me is I got called to see someone who had died at home. And I arrived there and the home was packed with people and they were praying. And it was, in a way, I felt like I was a bit of an intruder into this sacred space, but it's still the opportunity to be witness to that, to be able to be present during that was, and again, I think that's maybe part of what my career was, probably the richest part of my career, is being able to be present with people during these times in their lives. And it's whatever I've given to people, I've gotten easily as much, if not more, back over the years.
That's beautiful.
Yes, that's really nice, Bob. I just wanted to take this opportunity to say thank you for joining us today. We've learned a lot. Every one of these sessions, Mallory and I have learned more and more about hospice care and what it has to offer. So, and also thanks for your many contributions over the years in your field. And we look forward to seeing you riding with us this September again. It's the month-long ride. I'm not going to challenge you to beat last year's, but I look forward to seeing you on there. So thanks again.
Thank you. Thank you for inviting me. I love talking about this stuff.
Wonderful.
Yes.
I just want to remind our viewers that the 2021 registration is open. So please go to thehealingcycle.ca and register your team or register yourself as an individual. Also this week, we announced that the first 200 people to register for the ride are going to receive a free dry fit t-shirt. I've seen them. They are stylish. They look great. So please make sure you go on and get registered ASAP so that you can get one of those t-shirts. Thank you again, Bob. It was wonderful to have you, and everybody have a great rest of their day. Bye.
Bye.
Bye-bye.